So before we start, I would like to, I know she just left, but I'd like to thank Jen Jones, who's been giving me some guidance and mentorship through my practicum, which I'm finishing up my master's at Drexel University, a master's in education. So also I'd like to thank Dan and the administration for providing lunch for you guys. What I'd like to do today is talk about stroke and how we can have an early detection, which we'll call for early action, quick action during a stroke alert. Just one more thing I didn't say, I'm Mike Abdalla. I work at Paoli. I've been there for 19 years in the ICU, and I worked 2 years prior to that at Lankenau on one of their tele floors. So we all know, we've all heard of stroke equals time. So again, here we are. How can we improve our care of patients that are experiencing stroke symptoms? We're lucky here at Riddle Hospital, as well as within Mainline Health, that we are doing a great job with getting our patients to the CAT scans and to higher level of care when needed. What I'd like to do is just go over some objectives that we can learn, that we can get patients maybe recognize symptoms a little quicker and get them to, again, where they need to be. Here's the first objective, which is identify signs and symptoms of stroke. List in-hospital patients who are at risk for stroke. Develop an action plan and to quickly and safely get our patients through the stroke alert process. Finally, assess and treat our patients with alteplase, which is also known as the clot buster. It's important for us, again, the symptoms. What are the symptoms our patients might be experiencing, and which patients are at risk? Let's go over the signs and symptoms. A decrease or a fluctuation in level of consciousness, as well as they may experience aphasia or otherwise difficulty communication, or actually with them possibly not being able to recognize our communication to them. They can experience a visual cut. Famous is the unilateral facial droop, facial numbness. They may have unilateral drooping or weakness, numbness in one of their extremities. Eye deviation. Double vision in one eye is common. Slurred speech, again, goes with that facial droop. And then vertigo or unsteadiness. Which of our patients can experience this? It's good to know for the nurses when they give report or when they're getting reports, same as well for the PCTs, which of their patients are at risk. So we need to get a good past medical history and current history of why they're here in the hospital. Those that are at risk are patients that have had a prior stroke, or patients that are advanced in age. They say as early as 73, patients are at risk for stroke, greater risk for stroke. Those patients that come in that are either peri or post-operative, patients with a recent MI, or also patients with endocarditis. The ever popular atrial fibrillation, new uncontrolled hypertension, patients that are post-cardiac catheterization, as well as patients that are post-carotid endarterectomy, or CEAs. That's the concern there, is that some plaque can dislodge during the procedure. So many patients are on anticoagulants currently, so often those anticoagulants are held pre-op, creating a more risky situation for those patients. Sometimes this is kind of not looked at or understood, is patients that have hypercoagulopathy states related to malignancies and the prolonged stay. I mentioned earlier, if we could get faster approach, quicker recognition of signs and symptoms, our patients will benefit. So here's a little tool, FAST, and what we can do is we can use this tool to see if our patients are experiencing these symptoms. Call 711, which will we will activate the stroke alert. You may recognize this patient who unfortunately is experiencing signs and symptoms of stroke. So Jen represents the facial droop, so face is the F. A is arms, that drooping. S is speech. They may have garbled or slurred speech. And then T, time is crucial, that we recognize when the patients are experiencing the first onset of these symptoms. So we're going to have next, we've established the symptoms. Now what do we need to do? There's a call to action, and it was brought to my attention that I am not a good speller, and I did not spell chaos correctly. That is supposed to control the chaos. So sorry about that. How can we control the chaos? Do that first quick call for help assessment, teamwork, communication, education, and getting that patient transferred as soon as possible. Let's just look again at that help, which is we're going to use that FAST acronym, which will get us to determine early signs. Call 711. Get blood sugar early on, because if somebody is hypoglycemic or low blood sugar, they can mimic signs of a stroke. Vital signs are very important, that we need to keep the systolic blood pressure less than 185 and the diastolic pressure less than 110. If they are equal or higher to this, then we'll need to treat them before we move forward. Teamwork. We all know that a code stroke alert, code blue, rapid response can be chaotic. It can have many people in the room, many people outside of the room, many people loud. So what we need to do is we need to have teamwork to help combat this. The first person in this is the primary nurse, the nurse that's taking care of the patient. That person will assess, reassess for any changes, and report. The IV team and the PCTs, so important. The IV team needs to establish 2 IVs, preferably an 18 gauge IV, as well as draw labs. Here at Mainline Health, we should be labeling those labs as a stroke alert, so it alerts the lab. PCT gets that blood sugar that I had mentioned, so important, as well as get continuous blood pressure and heart rate vital signs. The recorder, or the person that's documenting, very important, because we need to know the exact time documented of the events, when the symptoms started, what changes and what medications need to be documented, so that we can continue the treatment for the patient. The recorder also can keep the line of communication. They can establish a staff member who can be on the phone at least with radiology to make sure that the CAT scan table is ready and open for the patient to go to. Communication. Again, the primary nurse needs to be able to give a brief history of what the patient is here for, what the patient's past medical history is, what has led up to this event, what has occurred during and after the event. She needs to give this information to the stroke team as well as the neurologist. That's why we need to free that nurse up, so that they're not doing tasks. That's part of the chaos, so that that nurse could be free to do that one job of just strictly communicating and assessing. The NIH stroke scale can be done by anyone that's trained with the stroke scale. It is important that we get that scale number so that we know what the treatment the patient may need. And again, prepare the patient for CAT scan. Get that communication open, have that staff member that is able to communicate with radiology. Down here, I'm going to open up education, and that also is communication. It's education from the family or the patient to us, as well as us to them. The reason why I say that is the patient's family are typically the ones that, as well as PCTs, because they're in with the patient most frequently, that are able to notice any changes and when those changes occurred. For example, a patient's family may say, well, my mom was having breakfast and then all of a sudden she couldn't lift her arm. So we know that it was breakfast. We can even go as far as ask the hostess when they possibly could have dropped the tray off. So that will give us an even closer time frame of when the symptoms occurred. Or if you had just turned a patient and then a few minutes later, hour later, you at least know that when you turn the patient was fine, but somebody reports within that hour something has happened because now they're slurring their speech. So it's important for patients and families to communicate to us, and then we need to explain what is going on with them. It is very scary. I don't know if you've ever experienced a patient that is experiencing a stroke and what their family is going through. So we need to explain what is happening, what we are doing, and why. Why are all these people in the room? We need to do frequent vital signs because we need to make sure their blood pressure is low. We need to establish IVs and draw labs. So all that kind of letting them know what they're doing, what we're doing, will reassure them why we're doing it. Why a CAT scan? They may ask. We need to just simply say we need to make sure these symptoms are related to a stroke. We may know that a CAT scan may not determine ischemic stroke, but it may determine a hemorrhagic stroke, which will then change the plan of care for this patient. Why are we transferring to the ICU? They may get all scared with that. Or why are we transferring to the stroke unit? Because we need to keep a closer eye on them. It's just simple. Just we want to make sure that your loved one is taken care of as efficiently as possible. Last here is transfer. And it's important, again, sorry about the chaos, but it's important that we control that chaos so that we can get the patient transferred. Why do we need to get them transferred and how long? We need to get them to CAT scan within 25 minutes of the onset of symptoms. Ideally, we'll get a read from the CAT scan within 20 minutes. So a total of 45 minutes between the onset of symptoms to the read will then help us be able to treat the patient further if they need alteplase, which is that clot buster. Alteplase should be given in the ICU, but if it needs to, it can be given outside the ICU. Ideally, and I'll explain why in the ICU. Ideally, and for mainline health and guidelines, national guidelines, inpatient patients, in-hospital patients, should be given alteplase within 60 minutes of the onset of symptoms. There is a 4.5-hour window, but the outcomes, the negative outcomes, get greater further out. So in hospital, we like to get it done within 60 minutes. So this clot buster that I keep referring to, it's called alteplase. It is a high-risk medication, meaning what it does is it is a fibrinolytic which breaks down in a kind of cascade, breaks down fibrin or doesn't let fibrin create a clot. So by doing that, it dissolves the clot in a sense. So As a high-risk medication, we have to think of the contraindications. There's certain patients that cannot get it. The assessment and preparation prior to giving it, the administration and the monitoring, as well as documentation. So let's go to contraindications. Why wouldn't we give this? We would not give this to a patient who is actively bleeding, or a patient that has coagulopathy concerns. As any drug, hypersensitivity, patient with infective endocarditis, which we talked about the endocarditis earlier, history of intracranial bleeding, or a patient who has intracranial or intraspinal surgery in the last 3 months. Patient that has been receiving low molecular weight heparin treatment within 24 hours. Also, previous ischemic stroke within 3 months. The reason why this is, a patient that has had a stroke can be at risk for an ischemic stroke, can be at risk for having a hemorrhagic stroke. So someone who has had a stroke within 3 months, ischemic stroke within 3 months, cannot get the alteplase. Somebody that has had a serious head injury within 3 months, because of the nature of the injury in the head, they are more at risk. Uncontrolled hypertension. Assessment and preparation. Again, we have to have a baseline NIH stroke scale, obtain vital signs, cardiac monitoring, and blood glucose. That blood glucose is so important. Obtain weight via the bed scale. It's important for us to have an as accurate weight as possible because this medication is dosed per kilogram. Review the CAT scan and the lab results, as well as try to keep the oxygen saturation greater than 94%. Again, this systolic blood pressure, keep it less than 185 and the diastolic less than 110. So what we do here typically is we use labetalol push, or they can be put on a cardine drip or nicardipine drip. This establishing the 2 IV sites that I talked about earlier. It's so important, although we don't want to delay any treatment through any of these, it is important that we get 2 IVs because we cannot stick patients for IVs or blood draws once they get alteplase. So we would be kind of in a spot if we weren't able to get them. Insert any invasive lines, whether it be a central line, an OG tube, NG tube, or catheters. Foley catheters, it's important to get those in. Once the medication is given, we cannot put anything in until for 24 hours. Educate, educate, educate patient and family. It's a scary time for them. So, we're going to administer this. It is given as a bolus and an infusion. The total dose is 0.9 milligrams per kilogram, not to exceed 90 milligram total dose. Remember that. The bolus is going to be 10%, and it's going to be given over 1 minute push, followed by an infusion with the remaining dose, and that's going to infuse over 60 minutes. You're going to hang a saline flush at the same rate as the infusion for 60 minutes. That's just to make sure the patient is getting all the medication they deserve. So here, 70 kilogram patient, what will be the total dose? 0.9 times 70 kilograms is 63 milligram total dose. 10% of that will be the bolus, which will be 6.3 milligrams. It's a 1-to-1 ratio, whether it's push or in the infusion. So 63 milligrams over 1 minute. The infusion dose will be the remaining, so 63 minus 6.3 is 56.7, and again, that's over 60 minutes. So the infusion, the saline infusion, will be 56.7 mLs over an hour.
they running together, the saline and the TPA?
No, it's after.
Oh, yeah.
The saline is after this is all done. And what you will do is, so you have the bag, you take that bag down, in the same tubing,
Oh, okay.
you hang the saline, so that it's flushing through. Excellent question. And yes, TPA, it's also known as TPA. So here's a tricky one, kind of. 120 kilogram patient, which is what we are seeing more frequently these days. What will be the total dose? So not 108, that's our calculation, but we have to give a maximum of 90. 10% of that for the bolus dose is 9 milligrams over 1 minute. And then the infusion will be 81 milligrams over 60 minutes, followed by that bag of saline at 81 mLs an hour for an hour. It's important that we're monitoring neurochecks. This is why they go to the ICU, because neurochecks, it's going to be Q15 minutes for 2 hours, 30 minutes for 6 hours, and then Q1 hour for 16 hours, for a total of 24 hours. So they have to stay in the ICU for a total of 24 hours. We're going to assess for allergic reaction, as well as signs of bleeding. Assess for our intracranial hemorrhage, which would be a decrease in neurological, deterioration in neurological status, headache, acute hypertension, and vomiting. Again, those IV sites are going to be used for blood draws and monitor for signs of reperfusion. Has anyone experienced a patient that had reperfusion? So all of a, it's amazing. All of a sudden they have like feeling, and it just actually happened 2 hours ago in the ED.
Yeah, I had a patient with slurred speech when he came in, and by the time the TPA was like 3/4 of the way done, his speech had improved. He was joking around, laughing, talking. Family was so excited, so it was really great.
Yeah, it really is wonderful to see. A lot of hard work and medication, documentation. Patient's weight, vital signs, rhythm, neurochecks, any changes in neurochecks, medications, pain assessment and reassessment. The NIH stroke scale needs to be done at baseline with any changes and every 12 hours. If there are no changes for 72 hours, the NIH scale can be DC'd. We need to document any changes or interventions, the time of the alteplase bolus, time of initiation and completion. In conclusion, just want to focus again on FAST so that we can quickly see anybody can do this. The family, any staff member, anybody that is aware of this. Now you all can do it because I just told you about FAST. You probably have already known about it. But all you need to do, mainline health employee can just call 711 to alert a stroke alert, which is once we get that stroke alert, we need to have an action plan that is efficient so that we can get the patient to the CAT scan within 25 minutes. Alteplase is a little tricky. It's a high-risk medication, but that's why we do close monitoring. Here are my references. And before any questions, I would like to just play this game.
So does everybody have a phone?
So once I come up, once I get this going, you'll see the pin show up. They're going to put it up here. You enter that 704582.
Yes, just go to kahoot.it. And now you can put a nickname in, just
Oh
make it
yes, put
somewhat
a nickname.
professional. Mine's
So what
Curly.
will-
Okay.
what will happen is the question will appear, and then the answers. And what happens is on your phone, you'll get the colors of the answers, and you just have to hit the answer.
It didn't work for me. Why not?
Is it not coming up for you guys?
Okay. I hit this one.
Yeah, just hit the-
Oh, okay.
Like, can you just do www.
Oh, you have to do the www.
What's that?
Did anyone have any questions while we're doing this?
Okay, here we go. You in? Okay. Ladies? We're
So I
partnering
only
here in the back?
see,
no connection.
Okay.
I'm Ed.
you're Ed.
I'm Ed.
Ed and Pebbles. Anybody else need help?
What do you want your names to be?
Your Pebbles.
CEC?
Oh, yeah, he is.
I like Pebbles.
Yeah, that's cute.
So there'll be a couple easier questions, and then we'll get into the other questions which you may recognize. What month is it? So you hit the color of the one that you... You all got it.
Yeah, there you go.
Oh, no.
Which is the best hospital to work at?
What do you think?
You better have all said that. What are signs and symptoms of stroke?
Oh, can you hit all?
Yeah, just hit one.
Hit one, is it just?
Excellent. Ed is still in the lead. Pebbles and Debbie and Cece, you better get going.
Quick film.
Which patient has the least risk for an ischemic stroke? Ooh,
Oh.
Ed pulled ahead, right? Or was Ed first?
I think I was, yeah. Ed was
You've been first?
I don't know why.
Only nurses can call a stroke. The nurse notices that the right side of the patient's face is drooping. What should the nurse do first? Ooh, this is a fast group.
I don't know.
Oh my goodness. Which patient is at risk for their nurse to miss signs of a stroke? So our elderly patients may have dementia or may have difficulty already just from being their age, and we may miss that. We may miss signs. The nurse's patient just received alteplase. Which finding is consistent with intracranial hemorrhage? Excellent.
Hey, you guys are rock stars.
Which patient can receive alteplase? A patient excellent. And last one, once alteplase is administered, an automatic blood pressure cuff can't be used for 24 hours. Okay, so just to clarify that one, Ed, you're the winner.
Finally, my wife.
Oh,
Just to clarify.
Oh, jeez. I really get something?
Yes.
Yes.
It's new that,
that's
it's
huge.
new policy at Mainline Health that we can, a newer policy that we can use automatic blood pressure cuffs after they've been given alteplase. Same with, we could put the SCDs on. Any questions?
I'm touched.
Aw,
Thank you.
You're welcome. Thank you for coming.
excellent.
Thank
I will
you.
share candy,
Very
anyone?
nice.
Candy?
Thanks, that's
Thank
so
you.
sweet though.